Good morning, this is your teacher Rika G, and I'm here to discuss about pulmonary edema and acute respiratory distress syndrome or the ARDS. Before we officially start, please leave a comment below your name, your year and section, your teacher's name, and the word present so that your teachers can easily monitor you during this lecture. In order to have a better understanding about this topic, let's have a brief review on the physiology of gas exchange inside the lungs.
Respiratory system. To understand the process of breathing. In humans, the main organs responsible for respiration are present in the thoracic cavity. In the thorax region, the rib cage and a dome-shaped fibrous tissue, known as the diaphragm, are observed. Present within the rib cage are the pleural membranes, which enclose the lungs. The right lung is divided into 3 lobes: the right superior, right middle, and the right inferior lobe. The left lung is smaller and has only 2 lobes, the left superior and the left inferior lobe. Both the lungs are associated externally with small tubular bronchi, which unite and extend into the trachea. The trachea has incomplete C-shaped rings of cartilage, which prevent the tracheal wall from collapsing. The trachea leads into the pharynx, which is connected to the nostrils. As we breathe in air, the oxygen molecules enter the nostrils and travel downwards through the pharynx and trachea to finally reach the bronchi. From each bronchus, oxygen travels into the lungs. Within the lungs, the bronchus divides repeatedly to form bronchioles. Oxygen travels through these bronchioles and reaches the alveoli, each of which is surrounded by a network of capillaries. A section of one alveolus shows the presence of numerous alveolar chambers with pores. Blood, containing RBCs, is seen flowing through the capillaries. The oxygen molecules from the alveolus diffuse into the capillary and then get absorbed by the bluish-purple RBCs. This causes oxygenation of the RBCs, and a transition in their color from bluish-purple to red is observed. The blood moving into the alveolus contains RBCs and carbon dioxide molecules. These molecules are released into the alveolus. The carbon dioxide collects in the alveolar chamber. And then from the alveolus, it travels through the bronchioles into the bronchus, which finally reaches the trachea and is breathed out through the nostrils. So the process of breathing in air rich in oxygen is called inhalation. After the contraction of the muscular diaphragm, the lungs expand and the air rushes in, resulting in the inflation of the alveoli. During exhalation, the diaphragm moves up and the lungs contract. Thus, the alveoli deflate, causing the air to be forced out. This exhaled air is rich in carbon dioxide. This process of inhalation and exhalation is known as respiration, which is approximately 20 times per minute.
So this is your alveoli or alveolus. Your alveoli walls is made up of type 1 pneumocyte and type 2 pneumocyte. Your type 1 pneumocyte is a squamous epithelial cells that permits gas exchange by simple diffusion, and your type 2 pneumocyte is a round or cube-shaped secretory cells that produces surfactant, and this surfactant is vital because it reduces surface tension, which makes it easier for the alveoli to expand. Then inside the alveoli is just an air space. When you magnify the walls, and there you can see the respiratory membrane where the gas exchange between the air and the blood occurs, and it's very thin to facilitate the diffusion of gases. The normal lung remains fluid-free because of the continuous lymphatic drainage and a balance among capillary hydrostatic pressure, capillary oncotic pressure, and the capillary permeability. In addition, the surfactant lining of the alveoli repels water, keeping fluid from entering the alveoli. So the capillary hydrostatic pressure is the force that drives fluid out of capillaries and into the tissues, while the capillary oncotic pressure, or the COP, is the net pressure that drives reabsorption, or the movement of fluid from the interstitial tissues back into the capillaries. Or oncotic pressure is a type of osmotic pressure that is exerted by cells and proteins that cannot cross the capillary membrane. So therefore, they attract more fluids. And oncotic pressure is higher in pulmonary capillaries than interstitial fluids. So therefore, it opposes the hydrostatic pressure. In short, si hydrostatic pressure, hinihila niya yung fluid from your capillaries going to your interstitial tissues. Ang ginagawa naman ni osmotic ay ino-oppose niya. So, ang ginagawa niya, binabalik niya yung fluid from the interstitial tissues going back to your capillary. Yung pangatlo is the capillary permeability, or the ability of your capillaries to allow substances to pass through it, or it is also known as the leakiness. Kapag balanse itong tatlong to, yung hydrostatic, the osmotic, and the capillary permeability, nasa tamang lugar din ang mga fluids. At kokonti lang ang maglilik. At yung mga maglilik na small amount of fluids is tatrabahuin na ni lymphatic system. So your lymphatic system will absorb it and ibabalik niya sa circulation. And this makes your lungs free from fluid excess. Now, let's talk about pulmonary edema. So, pulmonary edema is a condition where there is an abnormal accumulation of fluid in the lung tissue, in the alveolar space, or both. Pulmonary edema can be classified as cardiogenic or non-cardiogenic in nature. In cardiogenic pulmonary edema, the origin of the problem is from the heart, while in the non-cardiogenic pulmonary edema, it may be due to the direct injury to the lungs, such as trauma, when there is an aspiration and even smoke inhalation. Then next is when there is a hematogenous injury to the lungs, or when there is a spread of infection into the bloodstream which later affects the lungs, such as sepsis, pancreatitis, and even multiple transfusions and cardiopulmonary bypass. And third is the injury, or when there is an elevation of hydrostatic pressures inside the lungs. Then lastly is when there is a blockage of the lymphatic vessels of the lungs. Now, here's the pathophysiology of the pulmonary edema. The predisposing factors for pulmonary edema include heart disease, the acute respiratory distress syndrome, and inhalation of toxic gases. And the most common cause of pulmonary edema is heart disease. What usually causes the cardiogenic pulmonary edema is the left-sided heart failure, or there is a left ventricular failure. When the left ventricle cannot effectively pump blood out of the ventricles into the aorta and the systemic circulation, filling pressures on the left side of the heart increases, and vascular volume redistributes into the lungs. Subsequently, the pulmonary venous blood volume increases, and the hydrostatic pressure will also increases. When the hydrostatic pressure exceeds oncotic pressure, the fluid moves out into the interstitium or interstitial spaces. And when the flow of the fluid out of the capillaries exceeds the lymphatic system's ability to remove it, the leakage of fluid persists until it reaches the pulmonary tissues and alveoli, causing pulmonary interstitial edema and impaired gas exchange. In non-cardiogenic pulmonary edema, the main cause is the capillary injury. This injured capillary endothelium produces cytokines such as the tumor necrosis factor and the interleukin 1. Cytokines has this chemotactic ability, or they have the ability to attract more WBCs in the injured site, resulting to influx of inflammatory cells such as the neutrophils, macrophages, and activated platelets into the lungs. Activated neutrophils releases a battery of inflammatory mediators, including proteolytic enzymes, the ROS or the toxic oxygen products, the arachidonic acid metabolites such as the prostaglandins, thromboxans, leucotins, and platelet activating factors. And these mediators extensively damage the capillary membranes and greatly increases capillary membrane permeability. This increased permeability allows fluid, protein, and blood cells to leak from the capillary bed into the pulmonary interstitium and alveoli, resulting to pulmonary edema. And this is the clinical manifestations of pulmonary edema. Number one is the hypoxemia. Since gas exchange only happens in the alveoli, now that it's fluid filled, the oxygen cannot pass through or cannot enter into the capillaries or into the bloodstream, causing hypoxemia. Other manifestations includes dyspnea or difficulty of breathing and increased work of breathing as a compensatory mechanism of the body, and then inspiratory crackles or the rills since it's a fluid filled. Same with the dullness to percussion over the lung bases. And pink frothy sputum is expectorated because of the leakage of some blood cells into the lungs, and carbon dioxide in the bloodstream increases. As a result of decreased cerebral oxygenation, the patient becomes increasingly restless and anxious, and there will be a sense of suffocation, and the patient is tachypnic with noisy respiration, with low oxygen saturation rates, and the skin is pale to cyanotic since there is no gas exchange, and the patient is tachycardic. For the assessment and the diagnostic exams, the patient's airway and breathing pattern is assessed to determine the severity of the respiratory distress along with vital signs. And the patient is placed in a cardiac monitor, and IV access is confirmed or established for administration of drugs. And laboratory tests are obtained, including the electrolytes, the BUN, and creatinine and CBC. And chest X-ray is determined to confirm the extent of pulmonary edema in the lung fields. The treatment of pulmonary edema depends on its cause. If the pulmonary edema is caused by the increase of hydrostatic pressure that results from heart failure, the therapy is geared toward reducing the volume overload, improving ventricular function, and increasing oxygenation. These goals are accomplished through a combination of oxygen and ventilatory support, IV medication, and nursing assessment and interventions. Oxygen is administered in concentrations adequate to relieve hypoxemia and dyspnea. A nonrebreathing mask is used initially. If respiratory failure is severe or persists, non-invasive positive pressure ventilation is preferred mode of assisted ventilation. For some patients, endotracheal intubation and mechanical ventilation are required. The ventilator can provide positive and expiratory pressure, which is effective in reducing venous return, decreasing fluid movement from the pulmonary capillaries to the alveoli, and improving oxygenation. Oxygenation is measured by pulse oximetry and by measurement of arterial blood gases. Next, management is using of diuretics. It promotes the excretion of sodium and water by kidneys. And furosemide or another loop diuretic is administered by IV push or a continuous infusion to produce a rapid diuretic effect. The blood pressure is closely monitored as the urine output increases because it is possible for the patient to become hypotensive as intravascular volume decreases. The intake and output, daily weights, the serum electrolytes, and creatinine are carefully monitored. As the clinical manifestation stabilizes, the patient is transitioned to oral diuretics. Next is the vasodilators such as the IV nitroglycerin or the nitroprusside may enhance symptoms relief in pulmonary edema by improving the ventricular function. Their use is contraindicated in patients who are hypotensive, and blood pressure is normally assessed in patients receiving IV vasodilator infusions. If the edema is result from the increased capillary permeability from injury or the non-cardiogenic pulmonary edema, the treatment is focused on removing the offending agent and supportive therapy to maintain adequate ventilation and circulation is required. Then for the nursing intervention, proper positioning can help reduce venous return to the heart. So the patient is positioned upright, preferably with the legs dangling over the side of the bed. And this has the immediate effect of decreasing venous return, decreasing right ventricular stroke volume, and decreasing lung congestion. Providing psychological support is also important to minimize the patient's fear and anxiety. And the patient who is receiving continuous IV infusions of diuretics and vasoactive medication requires continuous ECG monitoring and frequent measurement of vital signs. A bedside commode may be used to decrease the energy required by the patient, and if necessary, in order to carefully monitor urine output, an indwelling urinary catheter may be inserted.